Good evening, everyone. We're going to give it just a few more minutes here for people to log on, and we'll go ahead and get started, but thanks for joining us. All right, well, good evening, everyone. I would like to welcome you all to tonight's panel, in which we will be discussing the radiation oncology alternative payment model. My name is Aaron Bush. I am a radiation oncology resident at Mayo Clinic in Jacksonville and currently serve as the National Radiation Oncology Resident Representative to the American College of Radiology. Thank you so much for joining us tonight. I'm sincerely looking forward to acting as the moderator for the duration of this panel. We are extremely fortunate to have an expert group of panelists with us tonight. And on behalf of everyone listening, I want to thank each of you for your time and dedication to improving the United States healthcare system. I'd first like to introduce Ms. Marcy O'Reilly, who currently serves as the Radiation Oncology Alternative Payment Model Team Lead at the Centers for Medicare and Medicaid Services Innovation Center, where she spent over the past 4 years designing the currently proposed model. She has also previously participated in the design of the home health value-based purchasing model and the Medicare Care Choices model. She initially joined CMMI in 2014 with 25 years of healthcare experience and initially earned her bachelor's in nursing from the University of Maryland. Next, Dr. Joan Liu is a board certified radiation oncologist currently practicing at Russell Perot Radiation Oncology Center in Eureka, California, located in the rural Pacific Northwest. He serves as the president for the Council of Affiliated Regional Radiation Oncology Societies, or CAROS, and holds several leadership positions within the Northwest. Dr. Liu has firsthand experience with practice accreditation and the merit-based incentive payment system, or MIPS, within Marca's quality payment program. With areas of interest including payment reform, artificial intelligence, and quality improvement metrics, he's authored numerous journal publications, including a recent JCO editorial regarding the APM's potential impact on rural practices. He initially earned his medical degree and completed his radiation oncology residency training at the University of Texas, San Antonio. Finally, Dr. Najib Mohideen is also a board certified radiation oncologist, currently practicing at Northwest Community Hospital in Arlington Heights, Illinois, with over 35 years of clinical experience. He serves as the chair of the Radiation Oncology Economics Committee for the American College of Radiology and the chair of the Astro Payment Reform Work Group. He is also a member of the Medicare Evidence Development and Coverage Advisory Committee. He's authored numerous journal publications as well, with a recent Red Journal editorial regarding model insurance coverage policies. He initially earned his medical degree at the Armed Forces Medical College and completed his radiation oncology training at Loyola University Medical Center. Prior to the start of our discussion, I would like to hand off the microphone to Mrs. O'Reilly, who will be providing us with a summary of the current proposed RO-APM and covering the next steps.
Thank you, Dr. Bush, and thank you for inviting me to participate in today's event. As you said, I'm Marcia O'Reilly. I'm the team lead for the radiation oncology model. Next slide, please. Sorry, my slides aren't advancing. Thank you. So on this slide, you'll see a lot of history related to the RO model, and it even goes back further than this. But in 2015, we were asked, the innovation, or CMS was asked, and HHS was asked to write a report to Congress on a possibility of an alternative payment model. And you'll see some dates of how we got to where we are today. But most currently, in September 2020, the Center for Medicare and Medicaid Innovation published a final rule that established the RO model with a start date of January 1, 2021. And as a result of the ongoing COVID-19 public health emergency, CMS included an interim final rule with comment period in the calendar year 2021 OPPS and ambulatory surgical center payment system final rule to delay the start of the RO model until July of 2021. Subsequently, the 2021 Consolidated Appropriations Act included a provision that prohibited the implementation of the RO model prior to January 1, 2022. And currently, in this proposed rule, CMS is making proposals to address necessary changes as a result of this delay and a few additional proposed modifications to the model. Next slide. So just to start, for those of you, I saw the participant, I know a lot of you are very well versed in the model, but if there are any of you who are new to the understandings of the RO model, I just want to give a quick review. The RO model will test whether making site-neutral, modality-agnostic, prospective, episode-based payments to hospital outpatient departments and physician group practices, which include freestanding radiation therapy centers, for 90-day episodes of radiotherapy will preserve or enhance the quality of care furnished to Medicare beneficiaries while reducing or maintaining Medicare spending. The model is designed to encourage uptake of evidence-based care, remove the differences in payment across different care settings, and address historical instability in payment rates. The RO model requires participation from RT providers and RT suppliers that furnish services within randomly selected core-based statistical areas, or what we call CBSAs, that represent 30% of episodes nationally. Next slide. We have proposed in the current OPPS notice of proposed rulemaking to begin the RO model on January 1, 2022 with a 5-year model performance period ending December 31st, 2026. We have proposed to change the baseline period from 2016 through 2018 to 2017 through 2019. And we are proposing to lower the discounts on professional component payments to 3.5% and to 4.5% for the technical component payments. Additionally, we are proposing to remove brachytherapy from the list of included modalities on the RO model so that it would continue to be paid fee for service. And in light of the current public health emergency and several recent natural disasters, we are proposing to adopt an extreme and uncontrollable circumstances policy. This policy would provide flexibility to reduce administrative burden on model participation, including reporting requirements and/or adjusting payment methodology as necessary when such circumstances exist. We are proposing to exclude hospital outpatient departments participating in the new community transformation track of the Community Health Access and Rural Transformation Model, also known as CHART model, from participation in the RO model. For the CHART model's ACO transformation track, we would follow the same policy for overlap between the RO model and the Medicare Shared Savings Program ACOs. And finally, we are proposing to modify our overlap policy such that only hospital outpatient departments that are participating in the Pennsylvania Rural Health Model would be excluded from the model, rather than all HOPDs that are eligible to participate in the model. Next slide. So in addition to the proposals, we've also notified participants that we are removing liver cancer from the RO model because the treatment of liver cancer is rapidly changing and thus does not satisfy the model's cancer inclusion criteria. And finally, we have included clarifications to help address questions we've received from stakeholders and future RO participants related to the interaction between the RO model and the quality payment program. Next slide. And I just want to remind everybody, this Friday is the end of the public comment period for the proposed rule, and encourage you to submit comments on these proposals to regulations.gov. And before we get to the panel discussion portion of this evening, I would like you to do the following if you haven't already done so. These are some steps that you could take to get all the information that you need to participate and be successful under the model. So first, appoint an RO model lead for your organization. And if you wouldn't mind, while I'm going through this, if I called your organization and asked you who the model lead was, or asked to talk to someone that I could talk to about the RO model, what would that title of that person be? That would most likely be the RO model lead. If you would put that title in the chat, that would be greatly appreciated. So next, each participant should obtain their RO model ID. We've discussed this in many of the webinars. You want to do this, you need to call the help desk, provide the TIN if you're or tax ID number if you're a physician group practice or a freestanding radiation therapy center, and provide the CMS certification number, or CCN, if you're a HOPD or hospital outpatient department. And then we also need for you to provide the first and last name of the primary point of contact and their email address. This would likely be maybe your RO model lead. And then once we have that primary point of contact loaded into the Radiation Oncology Administrative Portal, we want you to register and log in for that. And then once you're in the Radiation Oncology Administrator Portal, or ROPE as we call it for short, please add other points of contact, primary, secondary, and most importantly, a legal contact. We can send information more freely when we have that contact information, and legal contacts are the ones who can attest to things like opting out of the model if you're eligible, or attesting that your NPI list is accurate for QPP purposes. So, and once you're in there, we need you to update any address changes, legal name, or doing business name changes. What we've found is this isn't always updated in PAYCOS, and that transfers over to ROPE. So once you have the primary and legal contacts in there, updating that kind of information is very easy to do. And then again, I mentioned the opt-out. See if you're eligible to opt out for performance year 1, which is proposed to be 2022. And then respond to calls or emails from the RO model team. Sometimes we get messages or emails from you guys that need a little further investigation. And then when we call or email back, we're not getting responses. So if you could do that, that would help you and us. Continue to attend the webinars. We have the requirements webinar coming up in September, and the quality measure and clinical data elements in November. We rearranged that from October so we wouldn't compete with some of the other professional organizations like ASTRO's meeting. So we pushed that back. And then remember, there's a lot of resources on the RO model website. And again, don't hesitate to send questions to the help desk, and that information is on the slide. Next slide.
I think that's all I had. If you wanted to add anything else off slides.
Nope, I'm good.
Okay, perfect. No, thanks so much for that summary. I'm sure it was very helpful for catching our listeners up to speed with the APM with all the recent changes over the last 6 months. I'd like to now move on to the panel discussion itself. So this will be centered around some of really the top 10 topics of interest within the RO-APM as pulled from the radiation oncology community. All the panelists will have an opportunity to speak for each topic if they wish to contribute. So I ask everyone to please refrain from speaking until the selected panelist has finished their initial answer. We'll hold an audience QA session after the panel, so please hold on to your questions until the end or enter them in the chat box as we go along, and we'll do our best to answer those at the end. And for if we run out of time, we can answer those offline as well. And so we'll move on to our first question here, and I'll just kind of go alphabetically to start. And so we'll start with Dr. Liu, and we'll just rotate from there for each question. And so for the first topic, just 30% of all eligible radiotherapy episodes will be mandatorily included within the RO-APM, determined randomly by zip code. This includes rural and urban locations alike. Is this appropriate? If so, why? If not, why? And what would you change?
Thanks, Aaron. That's a great question. There's not any specific data on the total number of practices among the about 950, whether they're classified as rural or urban. Since the definition of rural and urban can vary depending on what your criteria are. But we do agree that there's a significant number of rural practices that were selected for the model. And a lot of these practices don't have the administrative resources that a larger practice in an urban area may have, making it more challenging for them to participate in the model. So these are some very heavy concerns that such practices would have. So we feel that if these rural areas are going to be included, it would be appropriate if they were given the proper support to be successful. And so it wouldn't be appropriate if the urban and rural practices were not on the same playing field. And so I'd just like to contrast that with MIPS. When MIPS, under the MACRA program for which this RO-APM falls under, was implemented, the CMMI actually designated several $1 million in assistance given to various contractors that would give small and rural practices assistance to help them be successful in MIPS compliance. And that actually helped my practice be able to participate in MIPS. Such assistance does not exist in the RO-APM. And so that's why I feel that the rural and small practices may be unfairly disadvantaged with this mandatory selection.
I appreciate that response. Dr. Mohideen will go next.
Well, thank you. I think Join's points are really important about the support that's needed for many practices, including rural practice. So what I can say is that this model has never been tested before. So therefore, I have difficulty understanding why it should be mandatory, especially we need to understand what its potential impact is on practice viability or patient care. A more appropriate approach would have been for this to be voluntary. And then once it's voluntary, then it could lead to a broader program. Because if this is such a good idea, then practices should be willing and able to participate on a voluntary basis, and they should be given that opportunity. And it would also allow time for practicing the participating practices and CMMI to determine what additional modifications and considerations must be taken before you shift to a broader, or let's say mandatory participation. So I think that's the challenge. It is this is a trial, but I think there is no phase 1 or phase 2 data before you're putting this into a phase 3 mode. So that's my problem.
Yeah, and I want to just echo that, because there actually, believe it or not, there are some practices that actually want to participate in the model. There's actually some in some larger cities that I know of in my hospital system that were truly interested and thought that they had the support to be able to do it successfully, but yet they were not allowed to participate because you could only be among the ones that were selected in order to participate. And I think that's a loss, because there are some practices that are set up to be successful in such a type of an alternative payment model.
No, I appreciate that. I think those are all good points. I'd like to move on to Mrs. O'Reilly just for any other comments or response.
Yeah, thank you. Dr. Liu, you are offering what I was going to say is your comment about CMMI offering extra support for the rural participants in meeting model requirements. I really hope that you offer, when you submit comments to the proposed rule, that you will include those when we talked about the clarifications of what meets the QPP definitions. So I look forward to seeing, your ideas on how we could give that extra support. And, to Dr. Mohideen's comment about the mandatory or required participation, we have it in the initial final rule that was issued in September 2020. We do talk about selection bias and the need to, to actually do a site neutral payment methodology to help solve the issue where freestanding radiation therapy centers were concerned that they were getting paid less than hospital outpatient departments. If it had been voluntary, we did not feel, and we explained this in that final rule, that the hospital outpatient departments would participate in the model. So, I mean, we could reiterate and rehash that a lot, but, I hope you will. I think and then Dr. Liu's comment that there are people who would like to participate in the model that weren't randomly selected, and we do random selection for research reasons, that makes me feel that, there is something good about this model that you guys are appreciating if they want to participate, even though they were not randomly selected. So again, you can always submit comments through the help desk, questions, or through regulations.gov for this rule.
All right. Now, I appreciate all the discussion on that topic, and we'll go ahead and move on to the second one. RO APM reimbursements will be modality agnostic. Therefore, techniques such as 2D, IMRT, SBRT, and proton therapy will be reimbursed equally. Is this appropriate? If so, why? If not, why? And what would you change? And we'll start with Dr. Mohideen on this one.
Well, thank you. That's a great question, and I want to compliment CMMI in that I think in this situation, a modality agnostic payment is appropriate, but provided you can determine payment rates appropriately and establish a mechanism for ensuring that participating practices are able to see these adjustments. Let's say I purchase a new LINAC or open a new service line, or the practice changes different to what it was in the 2017 to 2019 baseline period. And just an example for the residents is, imagine in 2017 to 2019, it was not common to use hippocampal sparing whole brain IMRT for brain metastasis. But in 2021 or 2022, 23, that may be more common. Similarly, post-op IMRT for cervical cancer. These are all evolving where there's phase 3 data supporting that kind of treatments. So when you use these more expensive technology, you have increased costs to the practice. And I know that in the model, there is to account for these changes so that you can look at what's happening inside the model and what's happening in the rest of the fee-for-service world. And to account for shifts in practice, the RO model uses a tool like the trend factor. But the problem, and we'll discuss about the trend factor a little more in detail, or probably in some other context, but the trend factor, I can say, is influenced by multiple factors, external factors, conversion factor, what's going on in payment rates, not just the volume. So that is a somewhat of a crude tool to assess these fine shifts in practice that happens, like the examples that I quoted. So I think CMMI has to monitor this very carefully and make sure that the payment rates are appropriate. Now, as to one of the modalities that's been left out, that is the CMS proposing to omit brachytherapy. I think given the model's limitations, and we've discussed that many times with CMMI, that when you combine external beam radiation plus brachy, as it's commonly done in cervical cancer, very often in high-risk prostate cancer, we do that. The model underpays when you're combining external beam radiation with brachy. So given that, I think it's reasonable to exclude brachytherapy from the radiation oncology model. But I have to say that it doesn't address the overarching concerns that we have about the inadequate reimbursement for brachytherapy services outside the model in the fee-for-service world that have created access to care issues for this very important modality.
Thank you. We'll go to Mrs. O'Reilly next.
Yeah, I would encourage you, before I forget this thought, as I was rereading the proposed rule for OPPS, there are a lot of provisions in there about brachytherapy for the payment of brachytherapy outside the RO model. So make sure you include your comments on those proposals too. As well, I mean, the PFS, I think they might be too late. I think their comment period ended today at 5 o'clock, but I'm not sure which time zone that 5 o'clock applies to. But please submit those comments. I thank you, Dr. Mohideen, that we did listen to our stakeholders about brachytherapy when it is provided in conjunction with other modalities, and we are going to be working with everyone and looking forward to the comments coming in on how we might incorporate multimodality treatment, especially with brachy, which is, you know, provided by such a few number of radiation oncologists out there. So I appreciate all that input.
All right, thank you. Dr. Liu next.
Sure, that's a great question. I think my thoughts mirror that of Dr. Mohiuddin. The modality agnostic payments can have two extremes. You know, on one end, you could actually discount the extra work and the complexity of the various modalities and the work that goes into using them and devalue them. On the other hand, you know, modality agnostic payments forces you to assess the value of the treatments you're giving so that you're not indiscriminately giving the patient the most expensive and most complex treatment when it's not necessary. Both extremes are not good. There's got to be something in between, which leads to the next question is, when it comes to bundled payments, where do you start? We could do something as complex as, okay, let's do a bundle payment for all 2D treatments, for all IMRT treatments, for all proton therapy treatments, for all brachytherapy, and you can do it as a modality specific type of bundle payment. And what the RO-APM is doing right now is it's an ICD-10 based payment. So it's based on your diagnosis, we'll pay you this lump sum of money, and regardless of which modality you use, you decide. Or you could take even farther, you could say, okay, let's just take everybody that comes in your clinic, regardless of what their ICD-10 code is, and we'll just pay you a lump sum for every patient that you come in to treat. And then even farther, and this is what insurance companies do, they just pay their monthly fee and the insurance company takes care of everything, and they have to be the risk adjusters. Right now, I feel like the risk is being placed on physicians when I really feel like it's the job of the payer to manage risk in terms of the financial reimbursement. So lots of levels where we could take this, and I don't have the answer, but you know, obviously there are perverse incentives on either end. We just have to find out what the sweet spot is.
No, appreciate that. I'll leave it open. Any other comments for this question? All right, thank you. Move on to the next topic. Current base rates per disease site will be based off historical average of fee-for-service claims, which includes palliative and curative patients. So same question, is this appropriate? If so, why? If not, why? And what would you change? And we'll start with Ms. O'Reilly for this one.
So obviously, I'm going to say I agree with this, and it's appropriate, and go with how we have described it in our regulations, and you know, explaining how we came to this. Again, as Dr. Liu, you know, referring to managed care and insurance, it's balance, and there are patients that are all curative. There are patients who are all palliative, and they're somewhere in between. And we believe that, you know, that we have struck a balance between that with not even just for these two kinds of situations, but how we set up our national base rates. And then we also have the, you know, the case mix adjustment that will help address some of these things if you see more palliative patients versus more curative, or vice versa. So I will leave it to Dr. Liu and Dr. Mohiuddin to say what would they change about it.
Appreciate that. We'll move to Dr. Liu next.
So I really appreciate this question. And I think I can definitely speak on behalf of many radiation oncologists who feel that it would be inappropriate to include palliative care cases in the historical averages, mainly because, you know, palliative care radiation is typically much shorter courses. The goal is to get the patient symptoms under control and then get them off to whatever systemic therapy they need to be on, or to hospice, you know, so, or some form of supportive care. Whereas curative treatment is typically much more complex. It's longer. patients may be getting combined modality therapy, which involves more potential complications. And so the prevailing opinion is that the inclusion of palliative care cases, pretty much devalue the care that's being given for definitive curative cases. And I'll defer to Dr. Mohideen because I know he's has a lot of expert opinions on this as well.
Thank you, Join. If I may add to what Join said and what Marcy said, I think there is a huge difference in costs for palliation versus curative treatment. Just take clinical examples. Bladder cancer, patients coming with bleeding, you give 5 fractions and that's it. And then compare that with combined modality chemoradiation for a curative case of bladder cancer over 5 to 6 weeks. You can take prostate cancer, someone who has bleeding, you treat them in 5 fractions versus a course of IMRT, prostate cancer. You can go down the list of these 16 disease sites from breast to lung palliation to everything, and you'll see that short course fractionation to palliate symptoms is very different from curative modality treatments often combined with chemo. So I think it makes sense to establish a palliative episode of care and a curative episode of care. And I think that would appropriately value the base rates for these curative cases, except for brain mets and bone mets. The rest are all supposed to be primary curative treatment of those other 14 disease sites mentioned. So I think it would give us a much better idea of what the actual national base rate should be. The other part of this is also you're relying mainly on OPPS data because, as Marcy mentioned, fee-for-service data, freestanding data is very variable. Maybe they said that the variation was far too much. So most of the reliance is on OPPS data. And if you look at the professional side, the PC side, the technical side aside, the PC side, there are distinct differences between the services delivered in freestanding. Take E&Ms, there's a big difference in reimbursement in E&M codes in the freestanding versus what's billed in the hospital. So it would be ideal on the professional side for the PC component of this to blend the OPPS and the Medicare fee schedule professional data points. So clearly, I completely agree that palliation dilutes the value of the national base rates for these curative cases by just the many examples that Join and I just mentioned.
I appreciate that discussion. I think it's definitely something that's gone back and forth regularly over the last 6 months to 12 months. I'm just going to open it up. Any other comments on this topic?
This is Marcy. I just wanted to say that, that again, we're talking about, like, if we were in the managed care world, we would be doing the law of averages. And so those cases where you're doing five fractions for bladder cancer palliative, you're getting paid closer to the 6 weeks of thing than what the national base rate is based on. So again, there is some of that in play here. And then again, I want to remind that, we talked about the trend at national base rates. We are trending utilization based on PFS and OPPS, not just OPPS.
One additional thing, Marcy, is there's also miscoding that happens. And I can see that in my own practice. For example, patients being treated for bone metastasis from lung cancer. The ICD-10 coded is a lung cancer ICD-10, although the secondary diagnosis may be a bone metastasis. So there is corruption in the data from errors that are committed by hospital staff or freestanding staff for billing. So that also dilutes the national base rate. Just something I'm sure you must have done some cleaning up at your end when you calculated these rates, but that's also one of the concerns that we have.
Yes,
And just
I
to show we're not
understand
always,
that. But we can't roll for the, I mean, we do, we make concessions for miscoding, but if all of CMS relied it on, miscoded claims, nothing would ever, move forward. So we have to fix that problem on the side.
Right. I just wanted to say that, Marcy, you gave that example. I'm glad you mentioned that because if somebody's palliative bladder case was going to be reimbursed like somebody who was treated for curative, that would be somewhat of a distortion of what the cost of care actually would be. And you would be actually, what I would think, overpaying for something that should be a lower cost of care, therefore decreasing the accuracy of your data collection to know what actually the value of the care that's being given is. And obviously there could be perverse incentives of people, wanting to achieve the curative payment when they're actually giving palliative. I'm not trying to judge anybody, but when there are financial disincentives to do the right thing, sometimes that can affect how practice patterns are implemented. So in this situation, you would be inappropriately overvaluing the cost of palliative care. And the goal is just to get accurate data so that services that we give are paid appropriately.
And again, that's why we're doing the no pay claim, so that we can monitor truly the utilization, and then we can make adjustments in the future, possibly through, proposed changes to the financial model.
All right, appreciate the discussion. We'll move on to the next topic. The ROAPM will utilize episodic 90-day bundled payments to replace fee-for-service claims. If multiple treatment courses are delivered within this 90-day period for the same cancer type, such as bone metastases, it will not affect the final reimbursement rate. Is this appropriate? If so, why? And if not, why? And what would you change? And we'll just continue on with Dr. Mohideen.
Right. I think CMS has stated in its data that multiple treatment sites within an episode of care are very infrequent. Now, across the board, that may be true, but I would say this is an issue that needs to be carefully monitored and potentially addressed in future rulemaking, because just take the example of brain metastasis and bone metastasis. I would say that it's pretty common to find retreatment in those sites within 90 days. And we see that all the time. Patient comes in, has 5 fractions of radiation for palliation, comes in 3 weeks later, another site is hurting. So we're going to go through simulation planning and treatment for that. But it's also not uncommon to use expensive technology sometimes for caring for these patients. So patient comes in with a solitary brain metastasis, gets paid the brain metastasis bundle, has radiosurgery. 6 weeks later, you do a follow-up MRI. That lesion is settled. There's another lesion or 2. So you again do radiosurgery. So you're doing expensive treatments within this 90-day window, all of which will not be reimbursed appropriately given the bundle that you're in. So that's something that needs careful monitoring. That's what I would say. There's also the risk of, just like Join mentioned in the last case, withholding care till some artificial time point. So I'm seeing a patient 2 months out, and patient has a brain metastasis, and I say, okay, if I wait another 4 weeks, I could do radiosurgery, and then patient will be in a whole new episode. And that also needs monitoring, because you cannot withhold care or have some incentive to withhold care due to some artificial time point for an episode to pass.
I appreciate it. We'll move to Mrs. O'Reilly.
And all of those things are things that we plan on monitoring for. And I think, as Dr. Liu said, we don't want to throw stones at some people who may not be doing the right thing, but we will be able to monitor for outliers related to this. So definitely on our monitoring plan, Dr. Mohideen.
All right, and Dr. Liu.
Yeah, so I too feel that the 90-day period without recognition of any other sites is something that will definitely be felt heavily by rural and small practices that often see the higher burden of late stage cancers that are most likely to present as metastatic, and having scenarios where you need to treat multiple sites within a 90-day period. You know, screening programs are typically not as extensive as in larger urban areas. The primary care shortage is acutely felt in rural areas, so that people aren't necessarily getting screening tests or addressing symptoms on a timely basis. So often I'll see these patients in the emergency room with widespread metastases, and there may be multiple sites that need to be treated. I'll give you a case in point. I recently treated a patient with metastatic esophageal cancer and started an episode for palliation for his esophageal lesion. I did it using a palliative fractionation regimen, not the preoperative. So it was a hypofractionated over 3 weeks. With 1 week after his first treatment, he developed severe hip pain. And so in reviewing his PET CT scan, which wasn't didn't seem that prominent, we actually did find hypermetabolism in this guy's acetabulum, iliac crest, and femoral neck. Now, this occurred during the episode, just a week into his esophageal palliative episode. If we, and sometimes people don't make the choice because they're trying to game the system. Sometimes clinics just don't have the bandwidth and say, we just can't afford to go ahead and do another site and simulate them because we're already stretched those so thin. So what do? You send this patient to the ER for pain medicines. They get sedated, they fall, they fracture that limb. They have to go in for surgery. They have to go through rehab. What money have we really saved by not recognizing the extra work that's being done in addressing metastatic cases? So I just hope that CMS will consider these scenarios and how much of a burden that falls on the patients that are particularly in vulnerable areas.
Thank you, Dr. Liu. Any other comments for this topic? All right, we'll go ahead and move on. Next is to decrease Medicare expenditures, current discount factors are set at 3.5 and 4.5% for professional and technical components respectively. Again, are these percentages appropriate? If so, why? If not, why? And what would you change? I realize I skipped Dr. Liu next on the last question, so we'll start with you.
My opinion, and this is solely mine, is that I don't think discount factors have a role in an alternative payment model. They're just artificially, giving the payer a discount, and so of course you're going to save money if you're going to give yourself a discount. I think if you really want to avoid confounding an alternative payment model and really want to test whether it saves money, just get rid of the discount factor and really let's go with the bundle and see what happens. But I'll defer to my fellow panelists to get their viewpoints as well.
All right, Dr. Mohiuddin.
Right. So we don't want to spend half an hour on this, so I'll keep it brief. Now, I understand that why you need a discount factor, because you want this to be an advanced APM, and you need to have a nominal risk that's at risk in these payment models. So what our issue has been, yes, you've reduced the discount factor to 3.5 for the PC and 4.5 for the TC, but these discount factors are still too high for radiation oncologists to successfully participate in the RO model. In fact, these discount factors are higher than the normal amount of risk in other payment models, and a more reasonable discount factor would be around 3%. Let me just give you the overall picture of what's happening in radiation oncology. So this RO model is expected to save $160 million over a 5-year period from the 950 or so practices required to participate. But let's take a step back and look at radiation oncology, what we call as total allowable charges. like total allowable charges under the Medicare fee schedule. What you will see from 2010 to 2020 is overall there's been a decline of over 3% of $47 million in that time period, compared to what's happening in the rest of the House of Medicine, where there's a 17% increase in the allowable charges under Medicare fee schedule in the rest of the House of Medicine. So why do you need to take another $160 million from radiation oncology? Whereas the real excess expenditure may be in other areas within the House of Medicine. So Astro had done an analysis which showed that if you take a 3% discount, this would still save Medicare nearly more than $100 million over 5 years. So I think it's absolutely important to make sure that this discount factor is in line with keeping radiation oncology clinics functioning and making sure that it doesn't have a negative impact on disadvantaged and underserved population. There's a Mayo Clinic analysis which came out last year, which showed that the radiation oncology model as structured would result in significant reimbursement reductions, especially in cancers which are more common in the underserved population, cervical cancer and so on. So I think this current discount factors that are published 3.5% and 4.5% are still too high. And we really would like CMMI to reduce that down to 3%.
Thank you. We'll move to Mrs. O'Reilly.
Yes, we've had this conversation many, many times, and I do encourage you to send your include this, and not just that you don't like the discount, but any, good information related to what a better discount would be, but take in your public comments that you submit on the reg. But just for, we've had this conversation about power analysis and statistical analysis, and these are the rates that that if we do not, if we went any lower, the size of the model would have to increase. And I think we explained that if we went lower, it would have to go to a national model, or I can't remember. Or we went from 40% to 30%, and that's when we dropped them at the initial time. And then we explained that we couldn't do it lower without increasing the size of the model, but we did make some concessions to the model in these proposals by the base, changing the baseline period and removing brachytherapy and a couple of the other things that allow us to drop to this model, to these numbers in the model. So, if you have better ideas, or, not better ideas, but you know what I mean, give us concrete examples of what, you think could be the, somehow. And I do want to say these numbers aren't all higher than other models. The home health value-based purchasing model went from 3 to 8%, and they are proposing and they're going national, and they're looking at a 5% threshold. So yeah, we are not higher than everybody else. So I just want to clarify that. But again, send your comments in and we will look at them. Thank you.
Thank you. Any other comments on this topic? All right, appreciate it. We will move to the next question. Starting in performance year 1, a 2% quality withhold of the professional component will take place, which can be earned back based off predefined quality metrics and clinical data reporting. Are these quality metrics and the withhold itself appropriate? If so, why? If not, why? And what would you change? We'll start with Mrs. O'Reilly.
As we described in the previous rules, we said why we picked which quality measures we picked. Unfortunately, as you all know, that there are not great quality measures out there for specific to radiation oncology. And then the withhold is a artifact of QPP. There has to be somehow where we attach quality to payment, and this is how we do that to meet the QPP requirements to be an advanced APM.
Thank you. We'll move to Dr. Liu.
So yes, I have to admit I have some very strong opinions about this. You know, a lot of us were hoping the ROPM would have more meaningful measures. Well, first of all, you know, this is an alternative payment model. So already we've found some issues with the payment methodology. And then on top of that, if we're going to accept that, we also have the burden of having to report quality metrics. Fine. If we're going to do that, well, let's come up with some meaningful measures. But no, we ended up borrowing quality metrics from the MIPS program, which I already participate in right now. And the best that we could come up with was plan of care for pain, advanced care plan, screening for depression. And then they pulled one that wasn't used for MIPS, but is actually an NQF measure, which was, dissemination of the treatment plan, treatment summary within 30 days. These are all process measures. None of them are outcome. And so that's all I'll say about that. And then to withhold the quality, payment at the beginning, which is in contrast to MIPS, where you actually can earn a bonus 2 years for participating, just seems a little bit punitive. And then to have to do all this work to earn this this withhold. To do all this work, and this is just the quality metrics. I haven't even gone into the clinical data elements, which are much more granular and much more burdensome. But I'll stop there and allow the rest of the panelists to chime in.
And we'll go to Dr. Mohiuddin.
Right. So since Join talked about the quality measures, let me talk about the clinical data elements. And as you know, there is this aggregate quality score. Half of that is assigned to quality measures, half of that is assigned to the clinical data elements. And you have to complete that for over 95% of your patients. So this is why it is onerous. The clinical data elements provide information about cancer stage, histology, and a number of other things, intent of treatment. And we are required to report CDEs, or clinical data elements, for breast cancer, prostate cancer, lung cancer, bone mets, and brain mets. Now, obviously, the data elements vary by site, and the most labor-intensive one now is for breast, which has a number of factors that have to be included. Practices will have to make EHR upgrades in order to comply with the quality metrics, and this takes time and resources. You report the CDEs, the clinical data elements, using a template provided by CMS. This will take significant time, resources for practices to comply with this. They will have to invest in resources, because some people are saying they'll have to hire cancer registrars in order to ensure this accurate data reporting. And I'd be interested in knowing Join's cost to get all this done in a rural setting, because what we have heard, Astro has heard from some large Midwestern healthcare system, which has 8 centers, and it costs them $1.74 million to upgrade their system to be able to do all of this. So it's not cheap. So I think, and my request is that CMMI has to face in the CDEs, because it has to recognize the challenge associated with all these EHR upgrades, cost, training, manpower, etc. The quality metrics, yes, it's part of MIPS. It's a much easier problem to resolve. We can, even though they may not be truly representative of the quality, as Marcy and Join said, there aren't a great deal of quality measures, but we can report them fairly straightforward. But the CDE is a whole different issue.
Yeah, and I'd like to build on that. Go ahead.
Yeah. Join, any idea of cost to you to implement this?
Yeah, it would definitely be in the, at least for my practice, we're talking tens of thousands in terms of man hours of putting it in. If we were to hire somebody, it would be a lot more than what the CMS estimate of having a data, specialist in our practice would be. And, in a rural area, where do you find one? I'd really like to know. So a lot of this will end up falling on the physician after hours. Because the CDs that you talked about, Najib, was pretty much a template that's a Excel spreadsheet that we have to download from the radiation oncology portal, and it can only be submitted through the portal. That requires one to manually enter data about the patient that's specific to them. As you mentioned, their stage. Even with breast cancer, even the prescription, and all these reside in the EHR. But there's no way to seamlessly transmit this to CMS, so we'll have to do it all by hand. And so people have calculated that this adds anywhere from 20 to 60 minutes per patient. And so you think about a busy clinic day, all this is going to happen after hours. And then on top of that, with the with the submission and the time that's involved, that's pretty much not accounted for by CMS. I would definitely say that's certainly a huge burden.
Thank you. Any other comments on this topic?
This is Marcy. I appreciate and I'm trying and getting your input on the burden, and because that's something that we at CMMI, we talk about on a daily basis. So I want to make sure you guys know that. But we do also, like a few minutes ago, you guys were talking about how pulling information and getting information about the acuity of patients from claims isn't adequate, and this is one of the ways that it's a path to, our future on being able to set payments that are more accurate is if we had some of this type of information. So I just want to say, remind you of the reason behind getting the clinical data was it was in response to stakeholders saying that we need to understand better what the patients look like to set payments. So just a little reminder there.
Absolutely, and I totally agree with that. I guess the onus now is that the burden of the collecting that data falls on the physician practices, and so I've never heard of a clinical trial where the patients are the ones to enter the data for the principal investigator, but this is kind of like what's happening right now. We do want to get good quality data, but it's the onus on the practice to supply that. And so, with this burden, one thing I do want to mention before we move on to the next question is with MIPS, you all had a phased in approach with the quality metric submission. When it was implemented in 2017, practices could submit one measure and avoid a penalty just to somehow test the waters. And then things got ramped up, albeit very quickly, because come 2018, you had to participate for an entire year. I'm not saying that the ROAPM should allow us to just submit one patient's clinical data elements, but a phased-in approach would be very, very realistic in allowing practices to be more successful in their participation.
I would second what Join said. I mean, phase this in, because I understand what you said. You want to know upfront what is the stage, whether it's curative or palliative. That's easy information. But in breast cancer, you're going to have to write how much did the supraclavicular field get, how much did the PA axillary boost get, what is the tangent dose, what's the need for all that to re-enter all that into a CMS portal.
I'm going to ask a question. If we phased in the clinical data elements, like you said, you can't just enter it for one patient. You shouldn't really phase in the number of participants you submit for, because then you could pick and choose like which ones. But if you had to pick of the 5 cancer types and you don't have to answer today, you could send me a message or send it to the help desk. But if you had to pick which of the 5 cancer types that we were doing, collecting CDs on, what would be your wish list for the first one or the second one, or a subset, versus all 5? So just a little question back to you guys to think about, and let me know what you think. I know we're running over time, so I don't want to like keep moving forward on that, but I look forward to.
Yeah, appreciate those thoughts.
No, thanks everyone. It's great when we get into a little bit more discussion with each of these topics. And we do have some time. We have until 7:30, and we can do QA offline as well. We're getting through the questions pretty well here. So I'll move on to the next one. The historical experience adjustments will begin in performance year 1 as a blend between the RO participants' historical payments being 90% and the national base rate being 10%. If an RO participant is deemed historically inefficient, historical payments were higher than national average, then the blend will shift to a 70-30 ratio by performance year 5 to bring payments closer to national averages. Is this blend adjustment appropriate? If so, why? If not, why? And what would you change? We'll start with Dr. Liu.
Yeah, I just very quickly, this would be something that could be better implemented. The gestalt of the consequences of this is that efficient practice would be penalized, and inefficient practices would somehow be rewarded by having their higher costs not go down as much. But Najib has a really great way of explaining this. So I'm going to let him chime in.
I think I understand the goal. That is to the goal of the blend is to bring inefficient practices more in line with the national base rate. So let's say the national base rate for prostate cancer is, just take an arbitrary number, 20,000, and your historical data says that you're billing it out, your reimbursement is 40,000. In the first year, it's a 90-10 blend. But over the next 3 years, 30% is going to reflect the national base rate, and 70% would be your institutional rate. So it's a way of making sure that very expensive or inefficient practices come more in line with the national base rates. So, but the problem there I see is the blend does not recognize that some practices are operating very efficiently. Despite the use of technology and everything, they're operating very, very efficiently. And one of the things that we heard back when the first final rule came out and some data were published, is folks were saying that, you know, we are under the national base rate, but we've been classified as historically inefficient. So we really need a lot more clarity on how do you define which practice is historically efficient or historically inefficient? Is it just the fact that your base rate is below the national base rate? Or is it also a fact of let's say I'm practicing in an underserved area and I'm seeing stage 3 cancers, whether it's lung cancer, cervical cancer, I don't see the early prostates or the intermediate risk prostates. I'm seeing all very sick patients. Does the case mix adjustment or any other adjustment account for that? And does that take into account the fact that I'm higher than the base rate? I should not be classified as an inefficient practice. We need a little more clarity on all of that.
Thanks. We'll move to Mrs. O'Reilly.
Okay, and we can provide further clarity on this, but our intent was for historically efficient practices not to be penalized. We thought that we were doing just the opposite with the way we set this blend, and then we did want to move historically inefficient, those who were furnishing services that were well over the national average, bringing them closer to the national average without like all of a sudden putting them out of business because we set their rates, at 70-30 from the beginning. So our intentions were to ease those historically inefficient to the baseline without being too severe in the process. So, but I made a note, we will continue to bring information to, we could talk about this for a really long time because you know how when it comes to math, everybody does their math a little bit differently, but we will, I promise that we'll provide some more information and just keep figuring out a different way to explain it so that everybody understands it.
Appreciate it. Any other comments on this question?
Yeah, I think mainly it's just basically being fair. We just want to make sure that the efficient practices are rewarded at the same magnitude as the inefficient practices may be slowly penalized. So, with this 90%, 10% breakdown, an efficient practice will only realize 10% of the national base rate, which would be higher. So why not make that percentage a little bit higher to allow the efficient practice to be rewarded a little bit more for their efficiency? If you're going to only do it slowly for the inefficient practices, that's just playing around with the numbers there.
Yeah, and some of that relates to, is that the only criteria that determines a practice is inefficient, the number that you're below or above the base rate, or are there other factors that go into classifying a practice as inefficient or efficient? So that clarity would help.
Got it, thanks.
All right, I appreciate the discussion. We'll move on to the next topic. So the recently proposed 2022 Medicare physician fee schedule is set to cut radiation oncology reimbursement currently by 8.75% in the next year. How will this affect the RO-APM, such as the trend factor or anything else? And should any adjustments be made? And we'll start with Dr. Mohiuddin.
Right. So this is a great question, and I don't know what the answer is, but I'll just say this is very relevant to the RO model because the Medicare fee schedule cuts could impact the trend factor. Now, the trend factor is designed to account for trends in payment rates and volumes for radiation therapy services outside the model. So you're not in the model, but Medicare fee schedule and OPPS, Hospital Outpatient Prospective System, those payment rates and volumes are important. So CMS in their proposed rule has said they are planning to revise the volume component of this trend factor, because otherwise it's 2019 volumes by 2022 payment rates divided by 2019 volumes at 2019 payment rates. So they're planning to revise the volume component associated with these trend factor to address fluctuations in utilization due to national disruptions in care, such as, if anybody realizes, we are in the midst of a small virus these days, but and that can create significant instability. However, my contention is that instability is not just related to the volume component. As you know, in 2022, the Medicare fee schedule proposed rule for 2022, CMS is proposing cuts of about 8.75% across all of radiation oncology services. And there's some reasons for this, and you may have read about it in some of this is due to proposed changes in clinical labor pricing inputs. And some of this is because of the expiration of the consolidated Appropriations Act, which equates the conversion factor 3.75 cut comes in there. So in total, there's an 8.75 cut in the Medicare fee schedule proposed rule. In a way, this cut flows through to the RO model through the trend factor, because the trend factor is effectively an annual update on the national base rate. So it can change from year to year based on how these payment rates fluctuate, not just the volume, the payment rates fluctuates in the MPFS and HOPS. So if there's significant shifts in the payment system between these two systems, those shifts are captured and it impacts our radiation oncology model participants. So what I would suggest is, we should have some guardrails there. You have an 8.57% that should not be passed on to everybody in the model, because it's not because the cost of care has changed or you're providing different services, because there's so many external factors. So these guardrails should be fairly tight at shifts of about 2% to regulate the impact of the fee schedule and HOPS payment systems on the radiation oncology payment model. Otherwise, we won't get the stability we strive to achieve or the intent to achieve in the RO model. That's a convoluted answer, but it's a tough question.
Thank you, Dr. Mohiuddin. Yeah, definitely multiple layers of complexity in there. I'll move to Mrs. O'Reilly next.
Again, I will have to say that, I assume you guys have also submitted your comments onto the PFS rule related to this. And, we look at, we don't do this stuff in a silo between, what happens at the innovation center and what happens as what I call the big house over at CMS. We look forward to this and seeing what the comments are, and we will take that into consideration.
All right, thank you. We'll move to Dr. Liu next.
Yes, so what Najib had mentioned is very concerning. If these cuts of 8.5% can affect the trend factor for the ROAPM, there really is no protection or guardrails from the annual proposals that CMS puts forth. And so this definitely leads to the unpredictability of payments, which is exactly contrary to what the intent of the ROAPM, which was to provide predictable, reliable payments.
All right, thanks everyone for the discussion. We'll move on to the next topic. And so there are currently no adjustment factors to account for reimbursement changes related to the COVID-19 pandemic, should any adjustments be made. I know we've talked a little bit about volume changes already, so I'll let Mrs. O'Reilly start to clarify this.
Well, we have proposed a extreme and uncontrollable circumstances policy that, that I won't go into the details here, to look at the change in volume of services that occurred in 2020 to see if we will need to adjust the trend factor when we're using that data. So I'm not exactly sure what you're asking me here, other than I believe we did our part. We made an adjustment, so I think this question is more geared to the doctors here and what the other panelists and what adjustments they feel should be made. And again, I'll encourage you to submit those in your comments.
Thank you. We'll move to Dr. Liu.
Yeah, I mean, this could be applied to both the fee-for-service system and the ROAPM. I'm not aware of any fee-for-service, modifier or adjustment when we have to take care of a COVID positive patient or a person under investigation. Our department had to put up screening stations for everybody that was coming in. We, had to empty our waiting room and make people wait in their cars before they would come in. Everybody hopefully has a cell phone so we can call them when we're ready for them. Those that were COVID positive were treated at the end of the day. all of us had to don full PPE when we interacted with these patients, when they had their on-treatment visits. And these were only, PPE pieces that could be used once and then disposed of immediately. And so, and we had to develop a protocol to direct the workflow of where these patients would enter and exit the department. All this added significantly to the amount of time necessary to treat a patient. And if you have more than one COVID positive patient, that exponentially increases the workload on both staff, physicians, and the time needed to take care of these patients, let alone seeing them for their weekly visits. So if something like that is not considered for fee for service, it should definitely be considered for the ROAPM. I don't know how it would look, whether it would be per patient or for the department. There's various levels on which an adjustment could be made, but I don't know what the correct answer is, but definitely something that I think deserves more discussion.
Thank you. We'll move to Dr. Mohiuddin.
I think, Marcy, I think what Join said is very true. It doesn't have to be a wildfire or an earthquake or something that comes under this extreme uncontrollable circumstances, but just the fact that we are operating in this COVID environment. If we have a patient with COVID and cancer, that's a whole level of expense. But even otherwise, using PPEs, monitoring patients. The other part of this, what we are seeing is, previously my prostate cancer load used to be an equal blend between intermediate risk and high risk. Now you're seeing more patients with high risk disease. Same for my colleagues with breast cancer and other cancers. Because of the delay in elective surgeries and screening, we're seeing more advanced cases. And guaranteed, I agree, there's a case mix and a historical experience adjustment. The HEA data points are kind of fixed, but the case mix is a rolling 3-year average. So by the time any of this data factors in, it'll be year 2 or year 3. You have to take into account the extra expense of not just taking care of COVID positive cancer patients, all the PPE, staff monitoring, patient monitoring expenses, but also the advanced disease that we're seeing. So some kind of a COVID-19 adjustment to recognize that impact is what Join was referring to, and I think that's very appropriate.
Okay, appreciate it. For the sake of time, we'll move on to the next topic. Please explain the relationship between the RO-APM, advanced APMs, and a MIPS APM. How will the RO-APM be implemented for providers already participating in MIPS or other AAPMs? And we'll start with Dr. Liu.
Thanks. I think this is a very relevant question because I live and breathe MIPS, which was really the main pathway that radiation oncologists participated in MACRA when it became implemented in 2017. Basically because there were, unless you were part of an accountable care organization, there were no radiation oncology specific APMs out there. So my practice has been participating in MIPS successfully since 2017, thankfully with the help of some of the technical assistance provided by CMS through its contractors. And so we've been submitting our quality metrics. We've been doing our improvement activities. We did get an exemption from certified electronic health records. And so you would think that if you were mandated to participate in RO-APM, that you would then be exempt from participating in MIPS. That's how it works. You either participate in MACRA via a MIPS or via an APM. Nowhere did MACRA ever say that you had to participate in both. But it appears that the way the RO-APM stands, that there wasn't much communication between the RO-APM and the MIPS program. When I logged into my MIPS portal, it had no idea that I was selected for the RO-APM. The RO-APM portal had no idea that I was participating in MIPS. And the latest guidebook from Mathematica on the clinical data elements and quality metrics submission actually admitted in there saying that if I'm participating in MIPS, I should continue submitting quality metrics via the same mechanisms that I have been doing in addition to what I have to do for the ROAPM. This is double work and a double burden on eligible clinicians. It's got to change if these smaller practices are going to be able to successfully participate.
Thank you. Moving to Dr. Mohiuddin.
I think this is Lou's Join's area of expertise, and I would like to see what Marcy has to say about that, because that is an important thing. We're doing both. That we are supposed to participate in the RO model to reduce burden and improve quality of care for patients and so on. But isn't this double work?
Appreciate it. We'll move to Mrs. O'Reilly.
Yes, and so the reason we said that you would, and I don't know the exact words, and I don't want to be misquoted for misquoting what it says in the guide, and I don't have it open right now, is that if you felt that your practice would not meet the QP threshold to be eligible to be considered for an advanced APM, that we didn't want you to miss out on your MIPS eligibility. So we're saying that you should have both ready and in hand. And there was another question, something you said first off, Dr. Liu, and I remember you sending this question right away a while ago to the help desk. And now it just went right out of my head as I was saying that. It was one of the first things you said. So if you had some prepared notes, you might want to bring it back to my attention. But we are doing a webinar that talks about the interaction between MIPS, APM, all APMs, and ROAPM. And we did say that we encourage you to participate in as many APMs as possible. Do you remember, Dr. Liu, what one of the first things you said, and I wanted to comment on, and I missed writing it down.
Was that during this discussion?
Yeah, just when you first started talking and replied to this question, you said something. It'll come back to me, and maybe we can get back to it. If not, yeah. But we do. The ROAPM has, we have to conform to QPP guidelines, and we do that, and that's, there are certain guidelines. Oh, the CERT, I think it was the CERT
health record exemption.
The exemption, right.
Excuse me, I apologize for interrupting. We actually only have a few minutes left.
Okay.
So if we're able, we can address that offline, and then I'll put it back out in the comment box along with the rest of the presentation, if that's okay.
Sounds good.
So I'll just move to the last couple slides here. So just quickly, for you, Mrs. O'Reilly, what's the best way to submit these comments? That's through the website, since we've gone through it so many times, correct?
Regulations.gov is where the comments, if you just send them to the help desk, they're not official public comments. They have to go to regulations.gov. So when you click on the link on our RO model website, there's a link to the proposed rule, and then you can click from there to get to regulations.gov.
All right, appreciate it. And like we've said before, that comment period does end this Friday, September 17th, 2021. Clearly a lot of comments to be placed in there based off of this discussion. And so hopefully everyone listening and those that participated will do that. I'm going to go ahead and finish this as far as the conclusion of our panel. Thank you so much to all three of you that participated. This was a great discussion, very insightful for me, and I'm sure for everyone else involved. Definitely a lot of work left to do the next 5 days, and then throughout the next several months as we approach the January start date. As far as a QA discussion, I appreciate how much discussion there was here. Clearly, it could have gone overtime just with that alone. And so if there are any additional questions, since there's not any more time as far as for the chat box, please use this email address and you can send it to me and I can get that to all the panelists, or you can use the Twitter handles here from each of our panelists to directly try and send a question to them. Though if you'd like to get closer to Mrs. O'Reilly, I can email her for you as far as any direct comments there, though I definitely think that using that official comment submission box would be the best way to do it. But again, thank you everyone involved. We're out of time here at exactly 7:30, so appreciate it. thank you so much, and we'll go ahead and end the panel here. Thank you.
Thank you, Aaron.
Thanks,
Thanks so
everyone.
much. Yes, thank you, Marcy. All right. Thanks,
Thank you,
Ajit.
Marcy.
Thanks, Aaron. Bye.
Take care.